Welcome to Ask the Expert. Today we have, excuse me while I admit people who are still coming in, Doctors Braulio Marfil-Garza and Dr. James Shapiro, both at University of Alberta. And they're talking in Canada, and they're talking today about pancreatic islet transplantation, 20 years experience at University of Alberta. I'm just going to do a quick little intro, a bio on each of them. Dr. Marfil-Garza was born in Monterrey, Mexico. He graduated from the University of Nuevo Leon and completed a residency program in internal medicine at the National Sciences and Nutrition in Mexico City. The last year of his residency, he served as in the hospital there. And during this time, he developed an interest in translational research. He spent, I'm trying to let people in as we go. He spent a year as a fellow working on molecular interactions between obesity and hypertension under Professor Gerardo Gamba. And while working on these endeavors, he found a research platform both in clinical and experimental research interests, specifically on pancreatic islet transplantation. He started his PhD in surgery under the supervision of Professor James Shapiro in 2018. And since then, he's been focusing on developing strategies to optimize pancreatic islet transplantation, mainly through generating data to inform clinical shared decision-making and by working on how to achieve immunosuppression-free pancreatic islet transplantation. He'll be starting a clinical fellowship at the University of Alberta in August 2022, during which he'll acquire clinical skills to care for people with type 1 diabetes and those undergoing pancreatic islet transplantation. Additionally, he hopes to extend his research into patient-centered outcomes and understanding how the lives of people undergoing pancreatic islet transplantation are affected. He's also eager to start a clinical and research program focused on pancreatic islet transplantation in Mexico. So welcome, Dr. Marfil. And Dr. James Shapiro was born in Leeds, England, son of a family doctor. He developed a longstanding interest in liver and islet cell transplantation while a medical student. He's been on the faculty of U of A since 1998, where he now holds the Canada Research Chair in Transplantation Surgery and Regenerative Medicine. He was the lead investigator on the famous Edmonton Protocol, which everyone is aware of in this community, which is a cell transplant treatment for diabetes. He's the first in Canada to start clinical trials with human stem cell derived insulin secreting, and most recently carried out the first in human CRISPR gene edited stem cell islet progenitor transplant without immune suppression, in collaborations with ViaCyte Incorporated and CRISPR Therapeutics, Inc. His current translational lab is focused on generating autologous iPS islets for transplantation into patients with diabetes without immune suppression, and his team and collaborators are working on scale-up and manufacturing efficiencies to make this scalable and possible. He's also, in his spare time, I guess, he's director of liver transplant, living donor liver transplant, and islet transplant programs at the University of Alberta. His H-index is 73. His many awards include the Hunterian Medal from Royal College of Surgeons England and gold medals from Governor General and the Royal College of Physicians and Surgeons of Canada. He's a fellow of the Royal Society of Canada and fellow of the Canadian Academy of Health Sciences. He has a long and very well-lauded career in this field. So welcome, Dr. Shapiro, and thank you both for joining us to talk about this really important topic. You know, the fact that, pancreatic islet transplantation has been going on for 20 years at University of Alberta. You know, where is it going? What's the state of the science in islet transplantation right now? I guess we can talk about what's going on in Canada and, what's happening in the US.
Thank you, Monica. Thanks for having us. And we're obviously very excited to display the data for the 20-year outcomes in our patients. I think we've learned an awful lot in the last 20 years. I have to give Braulio massive credit for analyzing a huge database and digging a lot behind the scenes to get 20 years of data polished to a point where it could get published in a Lancet journal. So obviously we're very proud of that. Over the last 20 years, if I reflect back and look at the very first patients treated to where we are today, I think we've accomplished a lot. I think we've demonstrated that the procedure itself is safe, and it's a lot safer than it was perhaps when we first began, because we've learned how to eliminate the risk of bleeding and clotting in the veins going to the liver. That's a very small risk now for patients. The anti-rejection drugs, I think we've also learned a lot over the course of time in terms of what patients will tolerate in terms of treatment and side effects. What are the risks of cancer? What are the risks of off-target side effects from the medications used? And I think we've learned to use those in a better balance than perhaps we did at the very beginning. And certainly we've got impressive early outcomes. 78% of patients being able to achieve periods of time off insulin was unprecedented before we began those trials. So we are obviously pleased and proud of that. Yeah. We are struggling, I think, when I look at the long-term data to maintain insulin independence long-term. But I think the data that Braulio's very clearly shown out to 20 years is that we can maintain stable glycemic control with profound protection against risk of hypoglycemia in this cohort, difficult to treat cohort of patients. So I'm very pleased with that. And then finally, perhaps I should mention the sub-analysis that Braulio did with the two anti-inflammatory medications, the anakinra and the etanercept, medications that have been used previously in rheumatoid arthritis and Crohn's inflammatory bowel disease, being used here in our patients mainly on the basis of a trial that we did a study that we did in mice with Mike McCall, a graduate in the lab about 12 years ago. They're showing that the survival of human islets and the engraftment of a very marginal mass of human islets was massively increased by the use of these two agents. And it's pretty rare to get a translation from mice to clinic of that kind of approach. And here we are using drugs for 14 days, 2 weeks, and having profound impact out to 20 years. I think it's very impressive data.
Yes, I mean, because there is this I think this fear from the patient community, like, oh, well, I don't know if I want to be on these immune suppressive drugs for the rest of my life. But really, that's not the case, correct?
No, I think we've learned from the survival data. Braulio, what do you think? I mean, the survival data for the patients is robust. We know what the risk is now. We couldn't tell the patients initially 20 years ago exactly what that risk was going to be, what the material risk is. Now we can really quantify that with good, robust data in large numbers of patients and say, well, this is the potential risk. This is the potential risk you face every day with your particular personalized management of diabetes. Is it worth that risk?
Yeah.
Yeah, no, I agree. I see myself the next year, talking to patients and being fairly confident that I have some data, even from here, to tell them, this is going to be your risk for this outcome, right? That we did not have previously. This is the first one reporting, adverse events related to immunosuppression. The Miami group reported 20-year outcomes, which are fairly similar to what we reported too. But this study is the largest one, and 20-year outcomes, we can talk to patients with some data and say, you know what, I think, you're at this point where none of the conventional therapies have worked for you, and I can definitely recommend that you undergo an islet transplantation, right? So that for me as a clinician too, and going to the clinic in a couple of months, I feel really, really proud and really, really good about generating this data.
Yeah, I mean, for those that really are in this, situation where they have, hypo unawareness, or they cannot control their, their blood sugar well, and keep in range, and have these sort of dangerous hypos, et cetera, and excursions into hypers. I think that, this is a true opportunity for them to gain control. I recently met a woman at a dinner who had gotten the islet transplant, and it was really transformative for her because of her starting point and the way she's living now. So it has the capacity to really be life altering.
Yeah,
I think that's exactly right. But how do we move forward from a niche treatment that is so effective for a few patients that struggle,
yeah,
into a universal treatment that is good for all? And I think that's what we've got to look forward to now.
Yeah, well, that's the $1 million question. And what are your thoughts on that?
Well, for me, my own bias is we need to minimize the need for the anti-rejection drugs. We need to eliminate them if we possibly can. That may be a real challenge in patients with autoimmune type 1 diabetes, but it may not. We'll have to wait and see. And I think that the good news is there's a massive amount of progress going on in the embryonic stem cell derived field, and now in the iPS derived field. Making patients' own cells is technically possible. Will these be accepted in patients with diabetes? We've never before tested cell therapies in patients with type 2 diabetes, so I'm excited to see what impact we can have in type 2 diabetes as well as type 1. And maybe the patients that have had previous surgery where the pancreas has had to be removed. And in patients with autoimmune diabetes, what will we need to do to control autoimmunity and prevent it from coming back? Will gene edits be sufficient? Will we have to give chronic low dose of immunosuppression? Probably, maybe. Or maybe some other strategy that makes the patient reset their immune system to make them less at risk of recurrent autoimmunity. But I think the slate is a lot more promising now. We've got real tangible progress. We've got progress with the Vertex trials. We've got progress with the ViaCyte trials. We've got progress with these gene edits with CRISPR therapeutics. And I think we've got, a massive opportunity to move all these forward.
Yeah, I agree. Can I add something? Just, this what Dr. Shapiro is saying is probably the future. It's what's going to bring us a true cure, right? Or at least the closest one to a cure. But I would like to add, in my experience, and one of my primary objectives is, in parallel, hand in hand, we need to keep generating data. We need to keep generating patient-centered out. And this is it's going to be one of my focus next year, because those stories that you've told us, right? It's just one patient, but it makes you look at the therapy with different eyes, right? You can look at numbers, you can look at HbA1c, you can look at the creatinine levels, everything. But when you hear the stories, and Dr. Shapiro has done a great job in putting some of these stories together, but when you hear them, when you see how these therapies are changing people's lives, I think that is a great motivator for all of us working in the field. And also, and you remember the talk with Dr. Witkowski a couple of weeks back. He's saying that one of the things that the FDA, they're limited by the FDA, but one of the things that could change that is patient support, patient advocacy. And he was saying that they were having some trouble in engaging those people with type 1 diabetes that have had an islet transplant. And I think for us in the Edmonton clinical site, I think we have the best opportunity to gather those patients. I've talked to a few patients my own, just coincidence, and their stories are amazing. So I'm working on ideas on how to put them together, maybe some qualitative research, so we can put those stories out, some common themes, and that is going to be so important. The same as HbA1c levels, glucose control, everything. But the stories, I think that's going to be important for us moving forward.
Yeah. I mean, our focus here at Sugar Science is talking about the science, but behind the science are people. And even if they are in sort of, if they're well controlled in their diabetes, it still is a very, very heavy lift for them on a daily basis, with a lot of, constantly controlling it. And even with all the newest devices, the CGMs and the, even the pumps and everything that comes along with the technology, it still is a fairly heavy lift. The hypos, those can be very devastating, and coming into the hospital when you have a stomach bug and all these kinds of things. So I think you're right to kind of think about the patient picture as well as the data. And I wonder, and I think, right, you probably do that because you're in the clinic, which is so important. And I know right now there's an effort underway to sort of really rally clinicians in the US, young clinicians, as they enter into endocrinology and fields, pediatrics that, interface with type 1, and really kind of, get them, excited, I guess, about this sort of the work that you guys are doing, as well as, as remaining in endocrinology, and sort of giving, creating a stronger collaboration between these types of physicians and physician scientists. So I think that's all really good. I wonder, it does seem that Canada, to me, in talking to several scientists, it seems like Canada is a little bit ahead of things in terms of like trying to really push things forward for patients. Do you want to talk to that a little bit? I mean, we talked offline a little bit of how the FDA now is looking at islet transplants now. Instead of an organ transplant, they want to reclassify it here in the US as a drug. And they also, have just put a hold on Vertex progress in the clinical study. So how does that compare, contrast with what's happening in Canada?
Yeah, the FDA has sort of got stuck in a groove, in a record, and I don't quite know why. I don't think anybody in the field other than them really understands why. I would say that we've been exceedingly fortunate in Canada. We put the original data from the 7, 8, 9, 10 patients that we treated in the year 2000, 2001 to Health Canada and to our province. They reviewed the data, they approved islet transplantation as acceptable therapy, and they regulated it very similarly to the way we practice organ transplantation. And it's obviously been very helpful to us, to Canadians who've received islet transplantation, and made it very practical. We got funding from the government April 2001. So that was, literally less than a year from when the paper came out in the New England Journal. So we were very fortunate in Canada. I think we all expected the FDA would follow suit. We carried out a 10-center multi-center trial funded by the Immune Tolerance Network, published in 2006. It took some time to put together and coordinate. I think we all assumed that the FDA would use that kind of data to approve islet transplantation. But in fairness to the FDA, I went to meetings with FDA in 1999, and they've been consistent with their message ever since, that they would not allow islet transplantation to be regulated as an organ, but as a cell therapy, and it's as a drug, and it's created a lot of angst, a lot of perhaps misunderstanding, and it's really slowed the progress of the field, and there seems to be little getting away from that. We saw, last year, a lot of interest by the FDA in a company, an islet cell, moving forward with a regulated product under a biological license, and it was hoped that they and others too would follow suit, and they probably will. But that's very complex for universities to administer islet transplantation under those circumstances. The requirements for FDA legislation, the requirements are so heavy for biological licensure that the university institutions are not really best positioned to do that.
Yeah, I like what you said. It seems like, what Canada's approach is very practical, and it certainly allows for those, circumstances where people really are in desperate need of the transplant, rather than having to go through many different hoops to get it.
Yeah, and the other thing, like when I was trying to put together the paper, I kept thinking, okay, I want this data to reflect the reality of what could happen. Like this data that we have, it's, obviously we have a lot of clinical research going on, but it's real world, so to speak, data. It's data that's not all the patients are in a clinical trial where the follow-up is more strict, right? This is real world data, and this is what a clinical islet transplant program could look like in other countries such as the States, right? So right. I think, that's one of the biggest things. I hope that our data can be used to support further talks with the FDA to get this approval, because this is real world data. This is beyond clinical research. That's what mostly occurs in the US, right? So yeah. I think that's a big point.
No, it's a huge point. And yeah. I think that, you can use this Canadian playbook really to kind of think be more forward thinking about really how to get from point A to B, the stalled point where they are, to really be more inclusive of what's in the future. I have a question here from Vishal Parekh. What can be applied to the dosing of stem cell islets from the recent 20-year follow-up report? Either of you want to answer that?
I think
Braulio, you go ahead with that and I'll follow.
Oh yeah, for sure. Well, I think we can have complementary responses to this. So first of all, I think the dosing is one thing, right? This is what I'm gonna say. The dosing of the islets, it's been typically used as, more islets, better outcomes, and in a way that's true, right? In a way, in the paper we see that, obviously the patients that had sustained graft survival had more islets, more infusions. That's correct. But in the long term, 10 years after, 20 years after, we do see that patient factors might be actually equally relevant or more relevant to long-term survival of the grafts, and particularly insulin independence. It seems that insulin independence, you can get more insulin independence with more islets, that's okay, but maintaining that, it's more related to how the patient responds to the graft. So I think, islets and the dose of islets is one important thing. We can get some data here. We had 80% of our patients had more than 11,000 IQ per kilo, which is, fairly a known number that can be good to have these outcomes. But I think, a lot of work is needed to have the specific dose. And, another thing that we're doing, and this is kind of a spoiler of a study that's being reviewed, is, what levels of C-peptide are needed to maintain relevant clinical outcomes, such as freedom of hypoglycemia and even insulin independence. So all those things are very important. But I think Dr. Shapiro can comment also on the predicted or projected doses that will be needed in clinical trials.
Well, this discussion is sort of interesting and relevant to perhaps the Vertex trials, maybe the ViaCyte trials, and how many cells do you need to engraft of a stem cell product to achieve maximal metabolic sustained benefit over the course of time? Yeah. And one of the issues and opportunities here is that the stem cell products are far purer than the islet products are, far purer. The islets are, only 30 to 50% pure. Even when we say we purified them, that's we've cleaned up some of the exocrine contamination with the COB2991 cell apheresis type systems, but they are impure. But whereas the stem cell products are highly purified, and so our ability to deploy a full dose of cells without risk of portal vein thrombosis, if we're going to put them in the portal vein, that's another point of discussion. But if we are, then I think we can achieve a much greater islet engraftment mass. I mean, why not aim for a normal engraftment of a full complement of cells, more than perhaps there would be in the native pancreas, so you can afford to lose a few over the course of time. The risk of hypoglycemia by overdosing of islets is almost impossible to achieve. I mean, islets are beautiful structures, and they have this ability to shut off whenever there's a hypoglycemic environment. So the likelihood that you would overdose and cause a problem, I think, would be very slim indeed.
That's an excellent point, and one that I think, probably on some people's mind. I wondered if we would like to take any more questions. If anyone's there, you feel free to unmute yourself. Here's another question. To Braulio, what are the patient factors, biomarkers you suspect are influencing treatment outcomes?
Yeah, that's a great question.
Yeah.
And we did try to answer this in the paper. We saw that there were key differences in patients that achieved sustained graft survival. That is, more than 90% of graft survival during their follow-up. Let's say if they have 10-year follow-up, they had 9 years of graft survival, right? Those patients were older. They had more duration of diabetes. So that may speak about the senescence of the immune responses too. Obviously, the islet equivalents that were infused, but doing a multivariate logistic regression where we adjust for age at transplant, hypertension at baseline, macrovascular disease, the dose of islets, the size of the islets called the islet index, the insulin units, which were all significantly different, we found that the use of anakinra plus etanercept and a good engraftment within 1 year of transplant were predictive factors for long-term graft survival. So I think, in terms of the patient demographics, we did see something, but when you adjust for all of those ones, I think the engraftment at 6 to 12 months and the use of anti-inflammatory therapies are the things that predict. Naturally, one of the things that we didn't have the information, and I think this is vital, is about the immune responses. We don't know what's happening with their T cells, with their cytokine responses, right? With the regulatory T cells, specifically the profile, the auto antibodies that were present. All of these things are great areas of opportunity that we're going to be looking into as we move forward with other studies. Yeah. And I don't know if you want to compliment Dr. Shapiro and other factors that you've noticed.
No, I don't have all the answers on that one. So the patient factors are complex. They're complex to analyze, and I don't think we have very good measures of we're not doing detailed quantum dot analysis to look for what the autoimmune pathways are doing long term, what the alloimmune pathways are. We don't really have a good handle on that, and we don't have a good understanding, mainly because we don't have good histology of these cells. Once they're deployed in the liver, they've gone. They sit there, they engraft, we presume, but we don't really know beyond there what's happening from a immune point of view. I think if we had a better resolution of immune events, short and long term, we'd have a better understanding of the biology behind survival or otherwise, and then we could intervene with more rational therapies.
Agreed.
Sort of to your last point, we know that there's a heterogeneity in the autoantibody presentation in type 1 diabetes patients. Did you see any overlap with certain autoantibody profiles and success rates or not? Was there any? Did you dig into that data, and did you take a look at the genetic data, those who had the higher risk factors in the HLA regions? Is that like something you're doing next? So
we are doing exactly that. Professor Shireen Forbes in Edinburgh is looking at that in very great detail right now in our patient groups. I have to say that it's a very complex data set that we mainly because we don't have good measures of autoimmunity. We have a massive database of HLA typings for the donors and recipients. It's really complex because you've got donors, sometimes 2, 3, 4 donors go into one recipient. How do you figure all that out? So we're trying, putting all that data together right now, and Professor Forbes is doing a terrific job with the HLA team to do that.
Yeah, that'll be very interesting to see these data. And there's this whole is there any way to sample people's T cells? I know they're really kind of limited, and they're hard to purify because there's not that many of them in the blood. But I mean, once people receive the transplant, are you then sort of taking their blood and trying to determine whether or not that memory T cells are reactivated? Are you able to sort of mine that? You referred to the Tregs, like what's happening in that space?
We worked with Bart Rope for a while. He did some very elegant studies on our patient subset, but we've not kept up with the collection of data. I suppose when you get to a point where you've got a routine clinical program delivering clinical care, and it doesn't necessarily, at least the hospital systems and the government don't fund the level of research to the same degree. So as you'd expect. So we've been, I think, good at practicing islet transplantation, perhaps not as good at studying the human immune system interactions in the way that we could, mainly because we don't have access locally to an expert human immunologist. And that's certainly been a challenge for us.
what would it take to accelerate that program, outside of funds?
Well, no, I think funds and an individual that has the passion and the knowledge to understand that human immune system interface.
Yeah.
I was
Okay.
going to say
call
that,
for talent right there.
Yeah.
Yeah, exactly. There's a huge, can you hear me?
Yes.
Yeah, there's a huge opportunity here. When I first came, like I first learned about islet transplantation like 4 years and a half ago, 5 years. In Mexico, they don't teach it, we don't do it, right? So I learned about that. And when I came here, I saw a lot of areas of opportunity. One is that, right, the immunological side of things, but also like, and this is, probably me inserting myself in the program, but someone that is actually passionate about doing this clinical research, looking at the data and developing like a formal research program in moving forward prospectively, right? So I think that's a huge opportunity, and we will do that. I'm sure about it.
Yeah. I mean, the Sanger Welcome Group, just published a great paper, a Nature paper, where they looked at 119 healthy individuals, and they kind of drilled down. I'm sure you guys have seen this, on the CD4 plus T cell identity.
Yeah.
It's really interesting, and that it would be so great to sort of layer that kind of approach over what it is you're doing, because you've got the real clinical on the ground data with patients, and then they're coming at it from that event. It just seems like it would be a beautiful collaborative piece, and they did indicate, they pulled out some T1D associations, and they were like, okay, at the end of the paper, it's like, okay, next steps, we're going to head into some of these disease states. So who knows, maybe there's a collaborative piece there, but I do think that what you're doing up there in Alberta is superlative. The way Canada is operating is, exemplary. And if it would be great if perhaps, the FDA would sort of take note of all the good things that are happening up there, and really kind of, maybe rethink what, their approach is, and incorporate, some of the great approaches you've got going there, and I guess into their decision process. So if there's anyone else, oh, here we go. One more question. We're a little over time, so I'll take one more, just to respect your time. I know you're very busy, but the question is, beta-2 score was also statistically significant, but the C-peptide levels post-meal were no different between the treatment outcome. What were your interpretations?
Yeah, I'm assuming the question is regarding the baseline C-peptide levels, which were no different. And honestly, we didn't expect to see any differences because these patients are fairly homogeneous in the way they're selected for transplant. But the beta-2 score, that's interesting because that is post-transplant. And in this case, we chose the 6 to 12 months time point after transplant, because a lot of patients have infusions within the first 6 months. So we wanted to look at engraftment post, most of the infusions. And we did see that, these patients, even after a month, they separate, they have better engraftment. And that is not related to the dose of islets. There's something in the patients, because they had similar IQs per kilo. They separate in their beta-2 score, they achieve better engraftment, and that engraftment actually maintains over time. In terms of the C-peptide levels, they should be similar at baseline. And over time, obviously, it's different because they're surviving. The graft is producing C-peptide. But the beta-2 score, which includes HA1C levels, insulin requirements, fasting glucose, and C-peptide, gives you a more complete assessment of the graft function. It was actually better, and as early as 1 month post first infusion, which is interesting. And it's the first time that we've shown the long-term use of the beta-2 score in this population.
It's fascinating. Well, I would encourage those who have not yet read your paper to seek it out and reach out to either Dr. Shapiro or Dr. Marfil to discuss this at length, or even, thanks for putting your email in the chat, or even, discuss possible opportunities and collaborations. Thank you so much for the excellent work you're continuing to do up at University of Alberta. And it was great talking with you both.
Thank you.
Thank you,
so much,
Monica.
Monica.
Thanks for a great forum.